Dr. Robert Saw is our next speaker. He's a professor at UCLA. He holds many positions at that institution. He also did his medical school at UCLA, his residency and fellowship at Loma Linda and UCLA too. And he'll also be giving us a talk on lung cancer management.
Good morning or good afternoon, depending on where you are. I'm going to briefly cover lung cancer management and really going to focus on just early stage or stage 1 lung cancer for the sake of saving time. So with regards to ablation, there are thermal and non-thermal techniques that have been used over the years. The non-thermal being chemical, where you just simply inject a toxic substance and kill cells. There's alterations in cell permeability, particularly with irreversible electroporation and now with pulsed electric fields. And certainly there's mechanical disruption of the cells with histiotripsy. Of the thermal energies that account for the majority of ablation being performed today, they can be divided in simply heat-based and cold-based, the heat-based being most studied and used are radiofrequency and microwave, and to a lesser extent, laser and HIFU, and certainly cold-based cryoablation. So regardless of the thermal energy that you choose, you have to use an applicator or a needle to puncture or steer into the tumor in order to destroy or ablate it. Ideally, in the chest, this is going to be done under CT guidance, but the CT guidance also allows us to monitor that process of destruction. So the goals of tumor ablation are simply to induce cellular death within a designated target volume, and this should also include a ablative margin of at least 5 to 10 millimeters. As with any therapy, it should be accurate and reproducible, spare normal tissues, and avoid unintentional damage to normal tissues. And if you look at the images on your right, we can see that on the top image, there's a part solid nodule with a biopsy needle there. And so this turned out to be an adenocarcinoma, as one might expect. And you can see in the middle and the bottom images on your right, we bring in an applicator, in this case, a microwave antenna. And through the series of images, you can see that we're basically repositioning and confirming where that antenna is in and around the target tumor. On the bottom set of images, after a total of 10 minutes of ablation at 65 watts, you can see what looks to be kind of a halo or a ground, what we call ground glass attenuation, demarcating the ablation zone. So here on the bottom row of images, you see basically the timeline in this patient through 12 months. And so again, on the left, you see the original part solid nodule, the immediate post-ablation area with marked by ground glass attenuation. And over the ensuing 11 months, you can see there's an ablation zone that's fairly well formed and gradually involutes and stabilizes over time. Again, because we're not cutting the tissue out, we really don't know how well we did. I mean, you kind of have an idea of technical success, but really the mainstay of following these patients is through imaging and, again, clinic visits to make sure that they don't have tumor progression or incomplete ablation. So most of the literature focusing on early stage lung cancer and thermal ablation have focused on what we call the high-risk patient. So these are patients that have surgically resectable disease, but for one reason or another are rendered medically inoperable due to their comorbidities. To give you an idea of how many patients are out there in the population, Mary looked at the SEER database and looked at all comers with early stage lung cancer and found that just under 16% were not eligible for a resection due to their comorbidities. If you look at advancing age, you can see that that number it goes over 30% once you hit the age of 75 and older. ACOSOG in their Z4032 and 4033 trials attempted to objectify or kind of give objective numbers for what they deem or what we deem high risk. And so they came up with major and minor criteria. The major criteria of which you need one is an FEV1 or DLCO less than or equal to 50%. Minor criteria of which you need two are less depressed FEV1, DLCO, advanced stage, pulmonary hypertension, depressed LV function, resting or exercise hypoxemia, or resting or standing hypercapnia. So the current local treatments for stage 1 lung cancer are really based on what we deem as operable risk. And so for the standard risk operable patient, lobectomy is still the gold standard. For those patients who have higher risk but still can be operable, generally sublobar resection is favored. And then for the medically inoperable or high risk patient, in the past it used to be external beam radiation, but over the last maybe decade and a half, it's really been more the mainstay of thermal ablation and stereotactic radiation, which is a form of radiation that is more localized and targets much better. And over the years, certainly for those patients who had been previously considered for sublobar resection, many times in appropriate instances, stereotactic radiation and thermal ablation are being considered in even those patient populations. It's important to understand the goals of ablation for non-small cell lung cancer in that ablation provides only local control of the cancer. So for stage 1 disease, it can be used alone with curative intent, as in this high-risk patient population. But for stages 2 through 4, ablation should be combined with other therapies. Now, I'm not going to go through the mounds of data here for the sake of time, but I like this slide because it kind of compares everything through the lens of completed NCI trials for stage 1 lung cancer. So there are 3 trials here, the RTOG 236, which is an SBRT study with 55 patients, ACOSOG Z4032, which is a surgical series with wedge plus brachytherapy in 222 patients. And finally, we have the ACOSOG Z4033 trial, which is an RF trial with 54 patients. You can see, of course, the surgical trial has to be high-risk operable, whereas the other 2 are medically inoperable. Certainly, with grade 3 or higher adverse events, rests with the surgical series. And the overall survival is reported 71% at 3 years for the wedge plus brachytherapy, 71% overall survival at 2 years for the RTOG SBRT study, 56% at 3 years. And what's interesting about this is that for many years, it was deemed that ablation was inferior to SBRT. And but you can see with the ACOSOG Z4033 trial that the overall survival was reported at 70% at 2 years, and this is certainly comparable to SBRT. Interestingly enough, Crabtree looked at the demographics of the patients enrolled in these trials, and they found that the ones that were enrolled in the RF trial were significantly older and had lower diffusion capacities. Here are the current sort of societal and organizational guidelines for non-small cell lung cancer and ablation. So for stage 1A disease by the NCCN, it is an option in selected patients for peripheral T1, A, B, and C, as well as for multifocal cancer. For the ACCP, CIRCE, and ESMO, ablation is an option for stage 1 disease. CIRCE and ESMO qualify it a little bit and state that ablation is only offered if there are contraindications to surgery and stereotactic radiation. And for the Society of Interventional Radiology, in their position statement in 2021, they simply stated that for stage 1A disease, ablation is safe and effective with minimal complications and survival outcomes comparable to SBRT and sublobar resection. One of the benefits of ablation is that it preserves lung function. And here's some data from the Z4033 trial. So you can see that FEV1, FEC, and diffusion capacity are all preserved at 3 and 24 months compared to the baseline. And interestingly enough, the forced vital capacity actually improves of greater than 400 cc's or 20% at 3 months and sustained at 24 months. Most likely, we're doing a thermal volume reduction. And then one of the criticisms leveled at ablation is that the local control rates are not as good, which may be the case, but in our Z4033 trial, we found that 31 of these patients had no local recurrence, 13 had local recurrence, but they were all retreated very early. And we can see that at the end of 1 year and at 2 years also, that this did not affect overall survival. So I put a couple cases here, but I think I'd rather take some questions. And so why don't we do that? So I'll just stop there because these are just some illustrations of cases. But again, I think the landscape is pretty rich for thermal ablation. I don't think enough IRs are actually doing lung ablation, but I think there's a huge opportunity there. But again, there has to be a champion for it as you go into practice. Thank you.
Dr. Sugg, great presentation. Thank you so much. We actually have plenty of time for questions. So if you wouldn't mind going through the chat, what all we have?
Yeah, so first question is, do you have a cutoff for FEV1 or DLCO to do interventions?
Well, I mean, I think so no, I don't have a cutoff, but I have to look at the patient. Because if I had my second patient that I ever ablated, he could barely shave without getting short of breath. But I did him anyways and got him through the procedure. So I think it's like what surgeons say, right? They can look at the numbers, but then you eventually have to go look at the patient. And also too, very importantly in our field, because we use image guidance, we can see, can we approach this tumor around, like, let's say it was a patient with emphysema. Can we safely put probes in and ablate? Is there a passageway that avoids bulla and so forth? If there isn't, then you can't treat that patient because you might have a air leak that lasts forever, and maybe that patient is better off with stereotactic radiation.
Next question is, does the preservation of lung function differ based on type of ablation, so thermal versus chemo or cryo?
Well, so I didn't show the slides, but of the local therapies, if you look at surgical resection, stereotactic radiation, and thermal ablation is the only one that's been shown to preserve lung function over serial ablations even. Whereas surgery, of course, it's obvious that the more you resect, the more lung tissue and lung function you're going to lose. But what's not as well publicized is that there are many studies looking at stereotactic radiation. And of course, the dose has been modulated lower these days, but there is some incremental loss of lung function with each stereotactic radiation. Now, again, in somebody who's has some respiratory compromise, one event may be fine with stereotactic radiation, but let's say you have multifocal lung cancer, or for that matter, oligometastatic disease, where you may have to ablate multiple nodules over the course of a patient's lifetime. In those situations, then I think lung sparing is kind of the way to go with ablation.
Thank you. Another question, do certain types of lung cancers, so squamous or adenocarcinoma, respond better to ablation procedures?
There hasn't really been a whole lot of literature on exact cell type for lung cancer. I know there were some studies at Memorial Sloan Kettering looking at the subtypes of lung cancer, and they find, and so some may behave a little bit more aggressively, or you may have to be more aggressive in ablating. I think in general, if you're dealing with primary lung cancer, it's better to have larger margins because in radiation literature, there's been shown that in there's more microscopic spread that's apparent than what's apparent on CT. So the edges of what we see on CT, if you look at those specimens on histopathology, on average, adenocarcinomas have up to 8 millimeter microscopic extension, squamous 6 millimeters. So you have to be a little bit more aggressive with the lung cancers in terms of margins.
Thank you. And another question, what are your recommendations or algorithm regarding oligometastatic disease?
So I think, in a nutshell, what you have to do is you have to kind of decide whether it makes sense, and the patient ultimately has to be biologically favorable. So if you have somebody with oligometastatic disease to the lungs, you have to say, well, ideally, if it's limited to one or two organ sites, that's appropriate. But there has to be management designed around those two organ sites or those single organ sites. And what you have to decide is whether you can render somebody radiographically disease-free. And you also have to get an idea of the biology of their disease. So if you have 3 nodules at time 0, then you might want to wait another 3 months. And if they still have those 3 nodules with minimal growth, then that might be a candidate that would be appropriate, provided there's no other disease. But if they have 20 nodules at 3 months, then that's not a candidate for local therapy or aggressive local therapy. In almost all studies, whether you're using stereotactic, radiation, surgery, or a combination of this with ablation or just ablation, when you have oligometastatic disease, patients with on systemic treatment plus aggressive local management have significantly better progression-free survival and also, in some cases, overall survival compared to systemic therapies alone. But the goal is you have to be able to render that patient radiographically disease-free with your local therapies.
Thank you, Dr. Sub.
You're welcome.